Hello, friends and colleagues. It's a tremendous pleasure for me to be here with you, even if only virtually, to discuss functional outcomes after transoral robotic surgery. Hopefully next year we'll be able to meet again in person. Thank you to the organizers for giving me the opportunity to be a part of this. Here are my disclosures. So I wanted to focus on functional outcomes after TORS because a lot of attention is given to the oncologic outcomes for oropharynx cancer, but we know that these patients do well generally. And the real meat of the issue has to do with their functional outcomes. This is how patients will increasingly decide treatment options in the future, I believe. Now, historically, we've had very crude measures of determining outcomes after surgery, and these have been historically retrospective as well. The crudest, of course, is just gastrostomy tube rates, as is demonstrated here. But I'll take us through, I think, the best evidence that we have, both retrospective and increasingly a new body of evidence emerging prospectively that can help guide us and our patients in choosing the best options. So one of my colleagues at MD Anderson, Kate Hutchison, published this study in 2014. It's a very early, crude analysis of gastrostomy tube rates compared between patients treated with TORS versus those treated with IMRT, and showed a signal in favor of primary surgery. There was a subsequent retrospective study that was published from the late Eddie Mendez, our great fallen colleague from the University of Washington, where they compared patients who were matched by T-stage, so 88 patients treated non-surgically compared to 39 patients treated with TORS. And what they found was interesting and similar. So first, big difference in the risk of needing a gastrostomy tube within the first 3 months. So about 45% of the patients treated non-surgically required a PEG tube within 3 months compared to only less than 10% who required a PEG tube treated surgically. This held over time, so true, by a year, most of the patients who required a PEG had them out, but there was still a difference between the patients treated surgically and non-surgically. So we wanted to look at this as well. We did a retrospective study at MD Anderson using AJCC 7 criteria, and we wanted to include patients who were TORS eligible, so patients who had small primary tumors, non-bulky neck disease, and whether or not they chose to be treated with TORS or with radiation, we wanted to look at their outcomes. And we, of course, excluded patients who had a gastrostomy tube at baseline. What we found was even surprising to me clinically, but maybe shouldn't have been based on the prior data. There was a tenfold increase in the risk of needing a gastrostomy tube within 90 days of treatment in the patients treated non-surgically. What was most interesting is that the patients who were treated with surgery alone had essentially zero risk of needing a PEG tube. And if you compare by number of modalities, so surgery versus radiation alone, there was a huge difference between these. Even in the patients who required adjuvant treatment, either surgery and radiation or surgery followed by chemoradiation, had a substantially less risk of needing a gastrostomy tube within 90 days of treatment. One of the criticisms or potential criticisms of this was brought by our colleagues in radiation therapy. This was a combined study. When we gave the data to them to analyze independently, they did propensity matching analysis and found the same results, and that's what we published. We looked at weight loss as well, CTC AE dysphagia toxicity grade that includes weight loss was one of the outcomes because we wanted to make sure we weren't excluding patients who lost a lot of weight but narrowly escaped a PEG tube. But the results were similar. Essentially, patients who were treated with surgery alone had very little in the way of weight loss or dysphagia toxicity compared to patients treated with radiation alone. and this was also true in patients treated with multimodality therapy. So there are more refined measurements than just gastrostomy tube rates. While that's a good concrete outcome that patients can really focus on, we want to look at more granular detail. And one way to do it is with prospective questionnaires. This is a study that was published out of the University of Pittsburgh in 2017, applying the EAT-10 questionnaire to patients. And what we can see from their data is that there's a predictable pattern of recovery in patients who undergo TORS. What's very striking to me, though, is the baseline difference. So at postoperative day 1, there's a huge discrepancy between patients in their EAT-10 score. And while this generally improves by postoperative day 30, there's still a big range. So we have to keep that in mind in any functional outcomes measurement of dysphasias, that there are differences between patients at baseline that we need to account for. Here's a study that highlights this over a longer period of time. This was performed at the at Oregon Health Sciences University, where I was formerly on faculty. And this study tracked EAT-10 scores over the course of a year. And what we see, again, at baseline, there's pretty substantial error bars in the baseline EAT-10 scores, essentially overlapping between the patients treated surgically and non-surgically. No difference between those groups, but still considerable potential differences between individual patients. But by 12 months, you really get a clearer picture of what's going on. So patients who were treated with TORS alone preserved their swallowing much better than the patients who were treated with multimodality therapy, either surgery followed by radiation or surgery followed by chemoradiation. It's kind of a cumulative effect. Now it's not all swallowing, and others have looked at quality of life outcomes in patients comparing surgery to non-surgical outcomes. This was a study published from UC Davis in 2014, comparing patients treated with TORS and radiation to patients treated with chemoradiation. They were matched by tumor and nodal stage. And what they found using the University of Washington Quality of Life score was that there was not a lot of difference between the two groups at a year, but there was a difference in their swallowing outcomes favoring surgery. So again, retrospective study, relatively small number of patients, but favoring surgical therapy in terms of swallowing. We did a retrospective study also looking at quality of life. This was a larger study, so we had 90 patients who were considered TORS eligible. They could either be treated with surgery or non-surgically, and measured the MDASI, so MD Anderson Symptom Inventory, as a primary outcome measure, and compared patients treated with single modality to those treated with multimodality. And what you can see in this heat map, which looks at individual item scores from the questionnaires, is that early on, in the patients treated with single modality therapy, they really favored radiation. We know this because patients treated with surgery have a lot of pain. They have trouble swallowing for a solid 2-3 weeks. This improves over time, of course, and by 6 months, even in the patients treated by single modality, favors the surgically treated patients. The story is different in the multimodality segment, where we see that by 6 months, surgery, while it's still favored, there's more favorable scores, questionnaire scores for patients treated surgically than non-surgically in the multimodality setting, even early on. Now, I've been very fortunate to work with a group at MD Anderson and have robust funding for routine patient-reported outcome measures of patients during their course of treatment, regardless of whether they're treated surgically or non-surgically. So everybody gets baseline assessments, including modified barium swallows at baseline, 3 to 6 months, and 18 to 24 months of treatment. And it was this registry that was the primary source of data for this study that was recently published by my colleague, Dr. Hutchison, looking at 257 patients who were considered TORS eligible. 75 patients had TORS, 182 were treated with radiation. And this was looking specifically at objective measures of swallowing. So what we've been talking about so far are subjective measures, questionnaires. This was looking at independent scores of modified barium swallows. And again, it was very interesting to me to see that there was a substantial amount of dysphagia, objective dysphagia at baseline. So the modified barium swallows in both groups showed objective evidence of dysphagia at baseline. Now, the takeaway from this study, again, done in a multidisciplinary fashion, was that for the entire cohort, surgery was favored over non-surgical management in terms of less objective dysphagia by a substantial difference. And if we look more granularly, we see that the patients who were treated with TORS alone had the best digest scores of any of the groups over the course of the study. And even if you include patients treated with surgery and adjuvant therapy, comparing them to patients treated with radiation or chemoradiation, it still favored a primary surgical approach. Now, surgery doesn't come without a cost, and I think we have to be honest as surgeons about this. This is just looking at those 75 patients who had TORS and looking at their MBS digest scores. Again, a substantial number of patients, almost a quarter of patients, had baseline objective findings of dysphagia on modified barium swallow. This increased to almost half of the patients in the immediate post-TORS setting, but by 6 months they had recovered substantially, but still with some dysphagia. So it's just important to keep that in mind, that that while surgery can improve the swallowing function of patients compared to non-surgical management, it's not without cost. We did a prospective study that recently wrapped. This was impacted by COVID, so it took longer to get our 12-month long-term activity data on patients, but we call it the Fitbit study, comparing the activity of patients treated with the primary surgical approach to a non-surgical approach. The feasibility of the study was presented at ASCO this year, and the data are just now wrapping up, and we hope to have available very, very soon. In the closing moments, I do want to talk about the ORDER trial. This is level 1 data, so it's a prospective trial, randomized trial, and it's something that gets talked about a lot and is very relevant, of course, to our patient population. This was a small study, so and it occurred over a number of years between centers in Canada and Australia. 68 total TORS eligible patients were treated, with the primary outcome measure being MDADI scores. So 34 patients were put into each group. Interestingly, a subset of patients were treated with single modality therapy, and I'd love to see these data. They have not been presented yet, but I think could be very telling. Interestingly, 2 patients were lost to follow-up because 2 patients who were randomized to non-surgical management dropped out of the trial. Here are the results. At 1 year, the MDADI scores were better for the patients treated with in the radiation therapy arm. The difference was statistically significant. It was 6.8 difference between the 2 groups, but compared to the standard deviation, much less. And looking at our own data accrued over a number of years, the MDADI scores reported in that trial are actually quite favorable to what we've seen in our reporting otherwise. What's interesting, and you'll see this in the manuscript, is that a priori a 10-point difference was considered clinically meaningful, to be a clinically meaningful difference for this group. And so while this study has been reported as a positive trial in favor of radiation therapy, it didn't meet its endpoint to be a positive study, in fact, to show a clinically meaningful difference. The study does have some flaws. They are very aggressive with the application of adjuvant therapy. So any N-positive disease received chemoradiation. Interestingly, a lot of patients received tracheostomy tubes prophylactically. That's because there was a death reported in the trial, and tracheostomies were recommended routinely after that. So most patients had a tracheostomy tube, and the application of adjuvant therapy was very generous, I would say. So most patients received adjuvant therapy for their disease. Again, there was a bleeding death and a near death in the trial, so tracheostomies were given very, very liberally. And I think taken together, it's remarkable that their swallowing outcomes were as good as they were, given that most patients underwent surgery with tracheostomy, and many had postoperative radiation or chemoradiation. But these data are out there, and I think important to know and discuss. We have data that we'll be presenting next week at ASTRA that I think will shed even more light on this and a more favorable view of primary surgery. But in summary, I think the toxicity of chemoradiation is well documented. We know that cisplatin-based chemoradiation is the current standard based on recent studies. But functional outcomes are increasingly important to both patients and providers, and helpful in determining how we best apply treatments to the patients. Surgery is really favored for well-selected, low-risk patients. I think the key is selecting the patients well. And I think we've shown here and in other studies that there is a marked difference in risk of gastrostomy tube rates, but there's even more subtle differences that can be determined based on prospective questionnaires and quality of life measures. So I'll end it with this. This is a patient of mine that I treated for TORS, and there was a story in the publication from my institution for this, and I had the pleasure of going out to dinner with him. He said, "You're not from Texas, you need to come with me and have a real Texas meal." And so I did, and I can tell you that I've had the opportunity to eat with a number of my patients over the years, patients treated surgically and non-surgically, and I would just admonish everyone to take up that opportunity. You learn a lot from watching a patient eat and the impact of the treatment on them. This patient did very well. He's alive, cured of his disease, and his swallowing is good, but even just watching him eat chips and salsa, you could see a difference from baseline. I think it's incumbent upon us to be aware of those functional hits and to document carefully how we are doing and to compare that to non-surgical management. So I think when we do this, it'll compare very favorably. Thank you again for inviting me, and I look forward to the discussions that we have virtually and in person hopefully soon.